Ladies and gentlemen, dear colleagues, good afternoon and welcome to this educational session. My name is Angelo Di Leo. I am a medical oncologist working at the Hospital of Prato in Italy. And I'm very pleased to introduce this session. This is going to be a session focusing on adjuvant chemotherapy for breast cancer. We will have 3 different lectures, and at the end we will have also time for interaction with the audience. You will see that during the 3 lectures some questions will be presented, and you will also see that information will be provided during the presentation for addressing properly the questions that will be presented. For those of you who have been invited to join this session and to reply to these questions, please pay attention to the questions that will be presented, because later on, after the end of the session, you will have to address the questions in order to get the MOC credits that you have been applying for. Now, let me start with the first presentation. I'm going to start the first talk, and this is going to focus on adjuvant chemotherapy in 2013, which patients, what regimens. I think you have seen my disclosure slide, and so I'm going directly to address now these 2 questions during my presentation. First of all, I would like to thank my colleague, Natalie Turner, who is a clinical research fellow in our institution and who has been helping me a lot in preparing this lecture. The first question that I am going to address is which patient should receive adjuvant chemotherapy in 2013? Well, let me start with an easy situation. Here we have a patient who is aged 40. She has a ductal infiltrating carcinoma. The tumor size is 22 millimeters, node negative, grade 3, triple negative breast cancer. I think that this is a good candidate for adjuvant chemotherapy, and I'm pretty sure that most of you, if not the majority of you, would agree with me that this is a good indication for adjuvant chemotherapy. The EBCTCG overview data are telling us that proportional benefit from anthracyclines in this specific situation would be in the range of 17%, and an additional proportional benefit of 14% would be achieved if we add taxanes to anthracyclines. Now, and with this I'm moving to the mock question. Let's assume for one moment that the patient has not node negative, but she has node positive disease. Do you think that the proportional benefit from chemotherapy would change because of the difference in nodal status? Here you see 5 different options. The red bar corresponds to the proportional benefit from anthracyclines, and the yellow one, the proportional benefit from taxanes. And you see 5 different situations. And the question actually is there any reason to hypothesize that the proportional benefit from chemotherapy would change because now the tumor is node positive instead of node negative? And the answer to this question actually is provided by the data coming from the EBCTCG overview. These data are telling to us that proportional benefits from adjuvant chemotherapy are independent of nodal status. So we should not expect to have a change in proportional benefit from adjuvant chemotherapy because now the disease is node positive. Of course, what is going to make the difference between node negative and node positive is going to be the absolute benefit from adjuvant chemotherapy, because in node positive disease we will have an increased risk of disease relapse. So even if we keep the same proportional benefit from adjuvant chemotherapy, we will have an increase in absolute benefit because of an increase in the absolute risk of disease relapse. Now let me move to a more controversial situation, the so-called luminal-like tumor. Here we have two important studies that have been run many years ago. At your right, you see the study run by the NSABP, and at your left, the study run by the SWOG group. The two studies were testing tamoxifen versus tamoxifen plus chemotherapy in early breast cancer patients. The NSABP study was testing the question in a population of no-negative, ER-positive patients pre or post-menopausal. The SWOG study was testing the same question in the population that was post-menopausal node-positive disease. In the last decade, we saw additional analysis coming from these two important studies, and these analyses were based on the evaluation of the 21-gene recurrence score on a primary tumor sample collected from some of the patients who took part into these clinical trials. And as you know, the recurrence score is allowing us to classify the ER-positive tumor into one of the three different categories: low, intermediate, or high score. And when we look at the results of these two retrospective analyses, we see that in the so-called high-risk group, we see the benefit from adding chemotherapy to tamoxifen, but in the low-risk group, tamoxifen or tamoxifen plus chemo have the same level of clinical activity. We have additional data supporting the concept that not all ER-positive patients are deriving benefit from adjuvant chemotherapy. Here we have 3 neoadjuvant studies that have been reported in the last years. In these studies, different genomic signatures have been used, but the conclusions are exactly the same. In these neoadjuvant studies, all patients received an anthracycline taxane-based neoadjuvant chemotherapy. A pretreatment sample was available, and the gene expression profile was evaluated on the pretreatment sample. Different signatures have been tested in these studies. You can see here the PAM50 signature has been tested in one study, the genomic grade index in another one, and the 70 gene signature or MAMA print in the third study. Now, without going into the details of each individual study, the bottom line message here is again that some ER-positive patients do not seem to derive any clinically relevant benefit from the use of neoadjuvant chemotherapy. However, we are aware of the limitations of the presented studies. We are dealing with studies where we have a modest sample size, and so of course this means that there is a potential risk of false positive, false negative results. There is a retrospective design, so these studies should be seen mainly as hypothesis-generating studies. And with the exception of the first two studies, the 21-gene recurrence score studies, all the others were lacking a randomly assigned control arm. In addition to these limitations, we are also aware of other data coming from the EBCTCG overview that are contrasting the evidence that I have just presented in my previous slides. The overview data, as you know, are based on a large number of early breast cancer patients. Almost 100,000 women have been evaluated for the activity of chemotherapy in early breast cancer. And these data are based on 123 randomized trials. As you know, the overview results suggest that adjuvant chemotherapy proportional benefits are independent of patients' age nodal status, ER status, and histology grade. However, we have also to admit that the overview data have also some issues that can at least partially limit the use of the overview results in clinical practice in 2013. The first of these issues is that ER-positive tumors are heterogeneous in terms of biology and also in terms of clinical behavior. And unfortunately, the overview cannot take into account the heterogeneity of ER-positive disease because no other biomarkers were evaluated in the context of these studies, and so it is not possible to split the ER-positive population into different subgroups. Second, the results for the ER-positive patients aged less than 55 may at least in part be related to the ovarian function suppression due to chemotherapy, and these results may tend to overestimate benefits deriving from chemotherapy cytotoxicity. So we suspect that in this specific cohort of premenopausal patients with ER-positive tumors, the final result that we are seeing is the combination of two different mechanisms of actions. One is cytotoxicity induced by chemotherapy, and the other one is endocrine effects induced by chemotherapy. Last but not least, the population evaluated in the overview does not seem to represent the majority of the population that we are seeing today in our daily practice. And I would like to spend a couple of slides on this last issue because I think this is quite relevant. We have been doing in my institution this type of analysis looking at the proportion of node-positive patients that we see in our daily practice, the proportion of node-positive patients that we see in the Tuscany region, and then the proportion of node-positive patients that have been evaluated in the overview. The overview data have been split in three different cohorts: the anthracyclines versus taxanes trials, the red bar, the anthracyclines versus CMF trial, the blue bar, and the polychemotherapy versus no polychemotherapy trial, the violet bar. And you can realize immediately then that the proportion of node-positive patients that we see in our daily practice is lower than the proportion of node-positive patients that we see in the overview. So this means that the population evaluated in the overview has an increased risk of disease relapse when compared to the population that we see in our daily practice. The other point is reported on this slide. Here we have been evaluating the proportion of luminal A tumors in our institution in Prato, the proportion of luminal A tumors in the Tuscany region, and we have been attempting to calculate the proportion of luminal A tumors in the overview. You can see that in our institution in Prato, the proportion of luminal A tumors is around 50%, the yellow bar. And this is very similar to the proportion of luminal A tumors that we see in the Tuscany region. In the overview, we cannot calculate the proportion of luminal A tumors because we are missing the biomarkers that would be required to calculate the proportion of luminal A tumors. But we know which is the proportion of ER-positive tumors. And if you look at this data reported at your right, you can see that the range of ER positivity in the overview is between 40 to 70%. Now, even if we assume that approximately 50% of the ER-positive population is a luminal A population, this means that in the overview, the proportion of luminal A tumors should range between 20 to 35%. That is much lower than the 50% that we see in our daily practice. Why this is relevant? Because luminal A tumors are expected to be less chemosensitive. So we could say that the population evaluated in the overview is a population that is potentially more chemosensitive than the population that we see in daily practice. So the bottom line message here is that the absolute benefits that we are seeing in the overview are most likely bigger than the absolute benefits that we are expected to see in our daily practice when we use exactly the same type of adjuvant chemotherapy. So let me summarize all this in one slide. I think that the conclusion is very controversial. We have lack of strong evidence in favor of or against adjuvant chemotherapy in luminal A breast cancer. And we have a series of trials, prospectively designed trials, that are now testing the question in the context of a large population. But what we should do in the meantime, when we see a luminal A-like tumor in our daily practice? Well, I think that we should still consider risk as a factor that can be important to decide whether or not the luminal A cancer should receive adjuvant chemotherapy. In my opinion, if you are dealing with a low-risk luminal A tumor, let's say a node-negative disease, you may perhaps want to avoid the use of adjuvant chemotherapy. If you have a node-positive disease with 4 or more positive nodes, this may be a case in which adjuvant chemotherapy can be recommended. And then we have this intermediate situation with 1 to 3 positive nodes where we are really uncertain about the potential value of adjuvant chemotherapy in case of luminal A cancer. I think that in this decision process, it's extremely important that we try to involve our patient. We should understand patient wishes and expectations regarding the use of adjuvant chemotherapy. Now, we are assuming that some luminal A tumors may avoid the use of adjuvant chemotherapy. Now, the question is for clinical practice, how can I identify in my daily practice luminal A tumors? And I think there are 2 strategies. One strategy is the gene signature strategy, and the other one is the quality-controlled immunohistochemistry. I think it's important to specify that must be a quality-controlled immunohistochemistry because we want to have reliable results. In some cases, immunohistochemistry can be very helpful because actually you can clearly identify with immunohistochemistry a luminal A-like cancer or a luminal B-like cancer, but there are some situations in which with immunohistochemistry you may have some discordant results. In such a case, I think it's really important to have a second pathology opinion. And if after the second pathology opinion the situation is still uncertain, I think this is a case in which there is no doubt that you should ask for a gene signature. The problem is that even when you ask for a genomic test, you may still have an intermediate pattern observed after that you know the results of the genomic test. In such a case, I think, again, that risk is an important factor to decide whether or not this luminal A cancer should receive adjuvant chemotherapy. Of course, luminal A cancer is not the only type of breast cancer where we can think to avoid the use of adjuvant chemotherapy. There are some uncommon histological types of breast cancer with a specifically favorable prognosis. And these tumor types are tumor types where we may think to avoid the use of adjuvant chemotherapy. I'm thinking specifically to medullary cancer or adenoid cystic cancer. As you know, these are triple-negative breast cancers, but they have a favorable prognosis. What I think is really important here is that we must be sure about the histological diagnosis, for instance, of medullary cancer, because the histologic diagnosis of medullary cancer can be quite difficult, so it has to be done by an experienced pathologist before that we are sure that we are dealing with a real medullary cancer. Now, let's go to the second question. Once the decision is made to give adjuvant chemotherapy, Should an anthracycline taxane regimen be the standard of care for all patients? Well, in the last 15 years, we have seen many studies attempting to identify molecular markers predicting the sensitivity of chemotherapy, of specific cytotoxic agents or specific cytotoxic regimens. But unfortunately, these studies have not been leading to any strong predictive marker to be used in clinical practice. So I think that there is a way to modulate the type of chemotherapy for each individual patient, but this modulation should not be based on predictive markers, should be based once again on risk of disease relapse. Let me summarize this in this slide. We have already mentioning that luminal A low risk are patients where we may avoid the use of adjuvant chemotherapy. Luminal A patients high risk should be candidate to adjuvant chemotherapy. However, here we could argue that we do not need to give an intensive chemotherapy regimen because we are uncertain about the benefit of adjuvant chemotherapy in this specific population. So, for instance, in this case, instead of considering anthracyclines followed by taxanes, we might want to consider a less intensive chemotherapy regimen, such as 4 cycles of docetaxel cyclophosphamide, or even, why not, 6 cycles of CMF, specifically in the case the patient is concerned about the risk of alopecia. For luminal B cancer, the situation is different. In my opinion, in case of a high-risk luminal B, there is no doubt that we should go for a sequential anthracycline taxane, but if we are dealing with a low-risk luminal B cancer, then we could once again consider some less intensive chemotherapy. In HER2-positive disease, there is no doubt that the most relevant systemic treatment is the anti-HER2 therapy, trastuzumab. And the question is which type of chemotherapy should be combined with trastuzumab. There has been a lot of discussion in the last years about the use of anthracyclines in this specific subgroup. Once again, considering the lack of well-established biomarkers predicting sensitivity to anthracyclines, I think that risk, and specifically tumor size and nodal status, should be the major determinants driving our treatment decision. So in a low-risk patient, we could avoid the use of anthracyclines. In a high-risk patient with HER2-positive disease, I would not hesitate to consider the sequential anthracycline taxane trastuzumab therapy. For triple-negative disease, in my opinion, we could keep the same type of treatment attitude as for luminal B breast cancer. Now, let me summarize in these last few slides which are the challenges for the future. I think we have 2 important challenges for the future. One is the intratumor heterogeneity. And the question is, should we target adjuvant therapy on the most prevalent tumor cell type, or should we target adjuvant therapy on the most biologically aggressive tumor cell type? And actually, we cannot address so far this question. This is an important question, but we are lacking the answer to this question. So we will certainly need additional studies addressing this question. And the other important question is how we could improve the definition of disease, risk of disease relapse. This is another important factor. We have been working a lot in the last 15 years about biomarkers predicting the activity of chemotherapy. But we are still missing something when we have to evaluate precisely the prognosis of breast cancer. Let me give you this quick example. These are patients coming from 2 well-known studies reported by Dr. Bonadonna and colleagues from Milano many years ago. As you know, in these studies, patients were randomly treated with CMF or no adjuvant systemic therapies. And you can see that after many years of follow-up in these 2 studies, some patients who did not receive any type of adjuvant systemic therapy are still disease-free after so many years of follow-up. So this is telling us that most likely we are still overestimating the risk of disease relapse. And this, I think, is going to be a challenge for the future, identifying exactly those patients who have micrometastatic disease and who need to receive some form of systemic therapy. I will stop here. I would like to thank my colleagues in my institution in Prato. Most of the slides that I've been presenting today are the result of fruitful discussions that I have with them when we meet to discuss adjuvant therapy of our breast cancer patients. And of course, I would like to thank the organizations that are supporting our breast cancer research program in our institution. And thank to all of you for your attention.